Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Chernayanu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. Welcome back to the breast cancer surveillance series. Today's episode will continue the discussion of breast cancer surveillance, and obviously this series would be incomplete without a discussion on mammogram risks. Now, in last week's episode, I touched on some of the limitations of using mammograms as an annual screening mandatory technology, considering the risk of cumulative radiation over many decades of annual screening, plus the discomfort and the fact that mammograms detect cancer. They are not detecting pre-cancer changes, and they're not detecting or picking up women whose breast health is at risk for developing cancer. By the way, with this whole conversation about mammograms, I am not targeting mammograms as the enemy. I'm simply pointing out that there are some major disadvantages to routine screening using an annual mammogram for over 4 decades. Not many people are pointing out the risks of routine mammograms, but there are some very significant consequences which you will not hear the majority of physicians talk about. But that's what I do in my podcast episodes. Provide you, the listener, with an alternative choice outside the norm of conventional medicine viewpoint. I like to imagine that all women, as well as their physicians, generally apply careful deliberation and logic to any medical decision. You're not doing something just because you were told to do it. One of the most serious risks of mammogram, and this is one risk no one is really talking about, is the unintended harm. Does the mammogram have unintended harm? Yes, it does. And such harm will come in 2 very specific forms. Number 1, the problem with a mammogram is it will detect quite a few breast cancers, which will not harm women during their lifetime. But the choice of breast cancer treatment, consisting of radiation or chemo or surgery or various combinations of these treatments, and their unintended consequences can unfortunately cause serious harm, maybe even possible death or unintended further cancer, either of the breast or another body system due to the chemo or the radiation. This is called overdiagnosis. There's plenty of information online about overdiagnosis, and it's actually provided on government websites, cancer.gov. Please look for the link to various websites that have valuable information about this issue of overdiagnosis. There are studies done, and the value of mammography, as well as the debate around it, has been featured in quite a few national websites and publications. For example, I did a little research and I found an article published in 2023, and I'll put the link in the show notes. This article talks about how a recent study adds to the debate about mammography in older women. That's the title of the article. And this is basically a commentary on a new study that suggests that the risk of overdiagnosis with routine screening mammography is substantial for women in their 70s and older. And this overdiagnosis risk escalates with increasing risk and other health problems, according to findings published on August 8, 2023 in the Annals of Internal Medicine. This study included over 50,000 women over the age of 70, and the findings were very, very interesting. And I'm going to give you the numbers here because I was pretty shocked. It showed that an estimated 31% of breast cancer among screened women was potentially overdiagnosed for the age group 70 to 74. An estimated 47% of women in the age group 75 to 84 were overdiagnosed, while 54% of cancers detected in the age group of over 85 would be overdiagnosed. This study was funded by the National Cancer Institute and raises the issue of whether harm from overdiagnosis is balanced by the benefits of detecting the cancer and the treatment for cancer, and for whom there is a benefit. Now, the concept of overdiagnosis is probably something you might have not heard of until this podcast episode. And just to make it very clear, because I'll talk about this next, the overdiagnosis does not refer to a false positive diagnosis, but it refers to the fact that the breast screening, the mammogram, will find true cancer, but will find a cancer that will grow very slowly or not at all, and most likely would never cause harm. Therefore, treatment would be unnecessary. But here's the thing, because current diagnosis methods cannot distinguish between such slow-growing, never going to kill you cancer versus the aggressive real cancer, all cancer is treated the same, which unfortunately exposes some women to the unnecessary harms and complications of sometimes very aggressive treatment. And because older women already tend to have a shorter remaining lifespan at the time of the breast cancer diagnosis, and because they are less likely to tolerate and recover well from all of the treatments necessary, the surgery, the chemo, and the radiation that are included, plus tolerate the hormonal manipulations like the tamoxifen use or aromatase inhibitors, which are blocking estrogen actions on the estrogen receptor-sensitive cancers. Because of all this, the prospect of overdiagnosis created quite a stir around whether such women should be screened for breast cancer or not. So pay attention, because maybe mammograms after the age of 75 might be a thing of the past. Now, interestingly enough, this is not necessarily intended to say we should stop screening after 75, but we should probably take into consideration that many very slow-growing cancers could take 10 years or more to actually cause harm. So it might actually be safer for an older woman over 75 with a slow-growing breast cancer not to know that she has it, rather than be told she has cancer, be aggressively treated for it, and have her quality of life destroyed or actually reduced by the treatment, as well as possibly die earlier due to the harm caused by the cancer treatment. So hopefully now you're more aware of overdiagnosis, and you can take that into consideration when you decide to screen after the age of 75, especially after the age of 80. Now, the second risk with mammogram screening is the fact that a mammogram can provide false positive results. And this happens especially in younger women or women with dense breasts. The psychological damage done to a woman's psyche and the disturbance in her emotional well-being due to a false alarm is not to be discounted. I have met quite a few women who refused to have a mammogram because of a previous poor experience, a very traumatic experience, caused by a false positive finding on a mammogram. It is entirely true that abnormal findings on a mammogram will sometimes, even though very suspicious for a cancer appearance, send the women being screened and her providers down the path of additional invasive imaging and much more invasive, painful, traumatic, and expensive breast imaging and biopsies to end up with the result of, oh, sorry, it was a false alarm, but yay, no breast cancer. Let's talk a little bit more about that. After the detection of an abnormal finding on a screening mammogram, first, we need additional images, which are required to confirm that this is indeed abnormal. This means you need a diagnostic mammogram, and likely a breast ultrasound along with it if you haven't had one already. And if you did, it might have been a screening breast ultrasound. You might be called back for a diagnostic targeted breast ultrasound. And depending on these findings, once the presence of the abnormal finding is confirmed, if it does remain suspicious, then the next step is a breast biopsy. Now, this is a process that could take months, sometimes a longer time. Imagine the stress, the fear, and the emotional turmoil that a woman has to live with for a few months or more until this is all completed. The majority of women are not really bothered by a false alarm. They're happy, they rejoice that at the end of this entire ordeal, they find out they have no breast cancer. They bravely keep going. Yay, let's get another mammogram next year and then another one next year. This experience does not deter them from continuing appropriate screenings because they want to continue to protect their breasts. However, we should not discount the negative experiences provided by abnormal findings on a mammogram, which again will be sending a woman down the path of emotional turmoil to find out in the end that all the expensive testing and all the stress could have been avoided had she not done a mammogram and had she decided to screen with a different method or not screen at all. All of this could have been avoided. That's the thought process. And this is what I hear from these poor traumatized women. Now, I do firmly believe that in the quest to avoid any liability or minimize liability on the parts of the imaging center and the radiologists who read the imaging, we screen and condemn many women to unnecessary diagnostic mammograms when a questionable finding is detected. Telling a woman her mammogram is abnormal and requires additional testing will generate anxiety. And large studies have actually shown that women with a false positive result on a repeat diagnostic imaging in 50% or more of the time will not follow up with the recommended screening mammogram when time comes for the actual next screening. Here are some statistics that are very interesting. 10% of mammograms require follow-up testing. That's 1 in 10 will need follow-up testing. Many researchers noted that only 7% of these abnormal mammograms eventually confirm a diagnosis of cancer. That means that 93% of additional testing required for an abnormal screening mammogram will yield normal, reassuring findings. What is also interesting is that the chance of a false positive result will increase with the number of mammograms a woman has in her lifetime. And apparently more than half of the women scanned and evaluated with an annual mammogram for 10 years in a row will experience a false positive result, with many of these women requiring a biopsy as part of the follow-up testing. Here's another kicker. For many of these women, the process of confirming there is no cancer in their breasts after the initial screening mammogram can take up to 1 to 2 years. That's crazy. Summarizing this very important truth that I need you to remember is that less than 1 in 10 of follow-up diagnostic imaging recommended when you have an abnormal finding on the screening mammogram will actually yield meaningful, scary results requiring a biopsy. Now, another stressful and annoying issue that many women complain about is that they're recommended to come back and have diagnostic imaging every 6 months for 1 or 2 years to ensure stability of the detected radiological change. I was one of those women almost 20 years ago. I decided to be a very good patient. I had my first screening mammogram at the age of 40. I had never had kids. I had been just 5 years or less on birth control pills, so I didn't have any family history, but I said, well, I'm going to be a good patient. I tell my patients to go get it. I should go get it, right? Of course, there was some kind of something seen on the mammogram. And of course, I had dense breasts. I was told to come in every 6 months. That went on for 2 years. After my 4th mammogram in 2 years, when I was told I need to come back in another 6 months just to be on the safer side, I looked at the radiologist and said, no. I'll be honest with you, I'm guilty as charged. I did not go back to have a mammogram for 5 years after that. And I'm not joking when I said earlier that I felt like slapping the very nice, very kind person who was very apologetic about touching my breast. Now, my experience with mammogram might be unique or different, but I find that it echoes in every other woman who comes for a routine exam and asks me timidly, is there any way I could do an ultrasound instead? I'm like, of course. I have a very honest conversation at that point about the pros and cons and limitations of the mammogram versus breast ultrasound versus thermography versus MRI. I let the woman make her choice. Doctors have to recognize that a false positive mammogram result will lead to fear, anxiety, and once the false positive result is confirmed, it can lead to significant frustration with the healthcare system. There are many potentially unanticipated and detrimental consequences of annual recommended screening for breast cancer, and we really should not minimize those. There is enormous pressure on women to follow up with their mammogram from the imaging center, who rightfully so will bombard them with letters, reminding them, hey, it is time to come back for your annual screening. By the way, we doctors thank them for that. Or if they fail to show up with the recommended additional radiologic testing, hey, you didn't come up for your diagnostic mammogram, you didn't come back for your biopsy. They also send us a letter, the doctor, when a patient fails to follow up as recommended. All of this is putting a lot of pressure on some women who feel overwhelmed and stressed and would rather just short circuit the visit in the doctor's office for an exam and, hey, just get me an order for a mammogram. Please email it to me. They want to make an appointment. They want to put it in the rear view mirror, so to speak, and they just want to feel reassured they have been screened and reassured they're cancer-free. Women have been conditioned to believe that the mammogram every year is enough to detect early cancer. They discard the notion that an adequate breast exam is necessary, as well as they discard the notion that self-breast exams should continue even after menopause. Women are also unaware of the value of alternative imaging techniques, and they do not receive any education or understanding how these techniques can help them screen for early cancer, especially thermography or the newest 4D breast ultrasounds, maybe even MRI in some cases. I don't want to get into the MRI conversation because it's just not covered and it's very expensive and it's somewhat uncomfortable, but there is no radiation. Now, women are not told that in order for a breast tumor to be detected on breast exam, it needs to be about 1 centimeter or more. For a slow-growing cancer, which is what the majority of estrogen receptor-positive cancers are, it could take at least 2 years and sometimes up to 10 years of cancer presence in a woman's breast to reach detectable clinical size, which is just a little bit above 1 centimeter. In younger women, who unfortunately have an increased tissue density of their breast, it could take many years before a cancer is detected on a routine mammogram or a routine breast ultrasound. So why not make thermography the screening technology of choice for younger women? It would avoid unnecessary radiation at a time when the breast tissue is more sensitive for it, and likely would pick up early blood flow changes and ominous metabolic changes, indicating inflammatory problems. Guess what? Inflammation most of the time equals increased risk of cancer. This will allow the woman to implement lifestyle changes and therapeutic measures which would meaningfully decrease or eliminate her risk for breast cancer. So why not? Food for thought. Now, I want to end this episode today talking a little bit how breast cancer screening is very different than screening for cervical cancer. When a physician does a pap smear, he or she is literally looking for precancerous cells, which signal a precancerous process, allowing for appropriate and early treatment, which will save a woman's life because it will prevent her from developing cancer. Because at that point, she will probably surgically need excision of the abnormal area of the cervix or would need removal of a cervix and the uterus probably entirely, early enough to prevent cancer. This is not what is happening with the breast cancer screening process that's using mammograms or breast ultrasounds, because we detect cancer. We do not detect precancer. Now, something needs to change, and we need to develop better screening technologies in order to detect women who are at risk for breast cancer. Because breast cancer screening using mammogram is literally just picking up early cancer. That's what the push is for, to get a mammogram once a year. So when you get the cancer, we got it early and we can cure you of it. It is never going to detect precancer or changes that would lead to cancer. Now, outside of testing for breast cancer, genetic mutations like BRCA gene or the Lynch syndrome, which sometimes many women have not even heard of, I sincerely hope that our early detection breast cancer technology, which actually exists in the form of a simple blood test, will be made available into the near future to all women, and not just women who have been diagnosed with breast cancer and who are in remission or being treated. The test I'm referring to is called Signatera by Natera and has been used successfully in many women who have been diagnosed with breast cancer and who are in remission to detect circulating cancerous DNA, free circulating DNA outside of a cell before it is organized into a detectable tumor or a localized cancer, prompting further evaluation with specialized imaging instead of bombarding women year after year with radiation of the remaining breast tissue. Now, this test is very expensive, upwards of $2,000. It is covered by Medicare and most insurance plans as long as you have a diagnosis of breast cancer. I do believe the powers that be need to fight to make this test available to all women or similar testing. And there is something similar called Galleri, which you have to do every year, that is picking up free-floating DNA. Any DNA that exists outside of the one contained in a cell, it's considered malignant in non-pregnant women, and that's the basis of the test. However, imaging breast tissue is the cheapest, safest, most affordable, easier to perform screening modality for breast cancer. Now, hopefully, this will change as genetic technology is advancing and testing for precancerous cells or free circulating DNA is becoming more and more mainstream, and as more and more women are aware that such testing exists. Now, I will end here and I will come back next week, continuing the conversation around best methods of screening, but also I'm going to talk about whether or not using hormone therapy in a lower dose versus a higher dose is going to be protective or not, or more risky for breast cancer. Or again, would you have more of a risk with higher estrogen or longer estrogen use? I will come back next week and talk more about that, but I sincerely hope in today's episode, I managed to open your mind to the significant challenges involved in detecting breast cancer early, as well as to the limitations that exist on relying totally and solely on annual mammograms. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas, so please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.